very lucky to be joined by our next critical care clinical pearl presenter, Dixie Pyles. Now, Dixie is the PGY2 critical care pharmacy resident at West Virginia University Hospital. Dixie, welcome. How are we doing this morning?
I'm doing good. How are you?
Doing great. We're recording, even though it's very cold where I am, colder than I would like. We're starting to get into spring. The dog days of residency are ending. And with that, of course, a lot of us in our medical ICU, we've seen a lot of our respiratory kind of illnesses start to creep up. And in some of our most critically ill patients, right, corticosteroids, they play a crucial part in management. So Dixie's going to ask the question, do we have a preferred agent or regimen when using this in ARDS? So Dixie, the floor is yours.
All right. Thanks, Nick. So, yeah, I'm going to talk to you guys today about steroids and ARDS and kind of just go through some studies and things like that. So, I'll start with the definition of acute respiratory distress syndrome has really evolved over the years. The most recognized definition that most people are familiar with is the Berlin definition, which includes it being an acute onset, having bilateral infiltrates on chest x-ray, having an identified risk factor for ARDS like pneumonia, trauma, pancreatitis. It can't be due to cardiac causes, and the P to F ratio determines the severity, with mild being 201 to 300, moderate 101 to 199, and then severe less than or equal to 100. There has been a new 2023 global definition that is very similar, kind of comes with all of the same things. The acute predisposing risk factor and everything like that is basically the same. And then they just introduced the fact that you can use bilateral B lines or consolidations on an ultrasound to diagnose as opposed to just a CT or chest x-ray. And then the mild, moderate, and severe categories are the exact same as Berlin, but they do expand the definition to include patients that aren't intubated that have ARDS. And so patients that are on high flow nasal oxygen of at least 30 liters per minute, as well as they have specific guidance for more resource limited settings without a specific PEEP or flow rate requirement. So it includes using something like SpO2 to FiO2 as opposed to the FPaO2 to FiO2 ratio. So ARDS has some established management strategies that have been used in guidelines for many years, like the low tidal volumes on the ventilator, proning and paralyzing for certain ARDS patients, and using a more restrictive fluid management strategy. The thing about steroid use in ARDS is that it has been studied for a really long time, since the 1980s, but it's become a more popular topic in recent years because there have been new studies published. In addition, the 2023 American Thoracic Society guidelines suggest using corticosteroids for patients with ARDS. However, they do not discuss drug dosing, frequency, or duration in the recommendation. So we really have to evaluate the literature to determine what we think is best to use for these patients. So, ARDS is an acute diffuse inflammatory lung injury, and steroids, as we all know, are used for their anti-inflammatory properties. So, it makes logical sense that we would use these steroids for ARDS. And the proposed mechanism specific to ARDS is that they reduce pro-inflammatory mediators, as well as a recruitment of neutrophils and macrophages during that exudative phase, which reduces damage to the lungs and reduces the impact on the permeability of the alveolar membrane. They can also promote clearance of alveolar edema fluid to benefit patients with ARDS as well. When we think about steroids kind of in general, it's important to remember how to convert between the different steroids as well as the amount of mineralocorticoid and or glucocorticoid activity that they have. So when we think about steroid conversions, thinking about the typical, septic shock dosing of 50 milligrams Q6 being 200 milligrams of hydrocortisone per day, that's equivalent to 7.5 milligrams of dexamethasone per day, 50 milligrams of prednisone, and 40 milligrams of methylprednisolone. So then thinking about the mineralocorticoid versus glucocorticoid activity, dexamethasone has only glucocorticoid activity. And then prednisone has more glucocorticoid than mineralocorticoid. Hydrocortisone is like equivalent, having both glucocorticoid and mineralocorticoid. And then methylprednisolone has minimal mineralocorticoid activity. So there have been various studies over the years, like I mentioned, for ARDS using different steroids and durations, as well as during different phases of ARDS. So I wanted to walk through three different studies that use three different steroids and different durations as well. So the first study that I'll mention is by Steinberg and colleagues. They published an article in the New England Journal of Medicine in 2006 that studied patients receiving mechanical ventilation, and this was more in the later phase of ARDS, so 7 to 28 days after onset, with a P to F ratio less than 200. These patients received methylprednisolone 2 milligrams per kilogram on day 1, followed by zero point 0.5 milligrams per kilogram per day on days 2 to 14, zero point 0.4 mg per kg per day on days 15 to 21, and then they tapered it off over days 22 through 25, or compared this to placebo. There were 91 patients in the placebo group and 89 in the methylprednisolone group, with a primary outcome of 60-day hospital mortality. This was not significantly different between groups. However, the methylprednisolone group did have significantly more ventilator-free days at day 28, with 11.2 compared to 6.8 days in the placebo group. And this was significant with a p-value of less than 0.001. The most impactful outcome for this trial was when the mortality was separated out into days after ARDS onset that the steroids were started. So like I mentioned, they kind of could include patients that were anywhere from 7 to 28 days after onset. So whenever they separated out into these different time frames, the trial found that 60-day mortality for greater than 14 days after ARDS onset was actually higher in the steroid group at 25% compared to only 8% in the placebo group. So what this study showed us is that the time frame in which we use steroids is really important, and that makes sense considering that the main mechanism for steroid effect that we talked about is thought to be in that exudative phase of ARDS, which is within those first 7 days. The next study that I'll mention is by Tongyu and colleagues that conducted a single center, double blind, randomized controlled trial in a Thailand medical ICU for patients with severe sepsis or septic shock receiving mechanical ventilation for hypoxemic respiratory failure with ARDS. These patients received our typical stress dose steroid dosing used in septic shock of hydrocortisone 50 milligrams Q6 hours for 7 days versus normal saline placebo. There were 98 patients in the hydrocortisone group compared to 99 in placebo, with a primary outcome of all-cause mortality at 28 days, which was 22% for hydrocortisone and 27% for placebo. So you can see based off of that, that the primary outcome being that all-cause mortality was lower for hydrocortisone, but was not statistically significant. They also looked at mortality at 60 days as well as ventilator-free days at day 28, but these were also not statistically significant between groups. The last trial that I'll talk about specifically is the DEXA ARDS, which was a multi-center randomized open label controlled trial in 17 ICUs across teaching hospitals in Spain. These patients had moderate to severe ARDS defined by a P to F ratio of less than or equal to 200 with a PEEP of at least 10 and FiO2 of at least 50% at 24 hours after ARDS onset. So you can see this one was using it a lot earlier on, so very early within the disease course at 24 hours. These patients received dexamethasone IV 20 milligrams daily for days 1 through 5, followed by 10 milligrams daily for days 6 through 10, or they received continued routine intensive care. There were 139 patients in the dexamethasone group and 138 in the placebo group, with a primary outcome of ventilator-free days at day 28 being 12.3 for dexamethasone versus 7.5 days in the placebo group. So this was a statistically significant difference with a p-value of less than 0.0001. They also looked at all-cause mortality in this study as a secondary outcome, with being all-cause mortality at 60 days. And this was also lower in the steroid group, being 21% compared to 36% with placebo, which was statistically significant as well. This had a number needed to treat of 7, so 1 death was avoided for every 7 patients treated. They also looked at adverse effects like hyperglycemia and new infections, which was not significantly higher with the dexamethasone group. So this is obviously not an all-inclusive list of studies surrounding steroids and ARDS. There are lots more that go back, like I said, to the 1980s, and most of these studies early on used methylprednisolone, and a lot of them found no difference in mortality, but most of them did see an improvement in ventilator-free days. Hydrocortisone has not been as well studied for ARDS. The study that I mentioned with this is that it was really one of the only ones that we used hydrocortisone in, but it could be potentially beneficial in patients with something like adrenal insufficiency because of its mineralocorticoid activity. Dexamethasone is the one we've most recently studied for ARDS with that 2020 DEXA-ARDS trial, and it was also found to be beneficial in COVID ARDS patients with the CODEX trial also conducted in 2020. One thing that is important to note about some of these older studies, so some of those methylpred studies that we see, is that some of them were conducted prior to the widespread implementation of ARDSnet. So most of these studies were not employing those pillars of management that we know to be mortality benefit, like the low tidal volumes with the ventilator. So I think this could have really impacted mortality being shown in these studies since we know that those strategies do have mortality benefit in ARDS. One of the big discussion points that comes up with steroid dosing in ARDS is that when patients have a concomitant disease state that can also be treated with steroids. So, and we commonly see COVID-19 patients, COPD exacerbation, severe pneumonia, septic shock, and these are all things that we commonly use steroids for. So SCCM did publish a 2024 focused update on guidelines for the use of corticosteroids in sepsis, as well as ARDS and CAP, to aid with steroid dosing in these disease states. However, they do not discuss how we handle treating someone that has multiple of these disease states, such as the ARDS and CAP, or the ARDS and sepsis. So there's other reasons why we think about why we wouldn't use steroids in these patients. So there are some of those concomitant disease states that you might want to avoid using steroids, which if you've been working in an ICU in the past few months, I'm sure you're very familiar with this, being that influenza has been particularly rampant this year, and a lot of our patients have ARDS caused by influenza. And this can be one of those situations where you determine what are we going to determine is the kind of causing factor and whether or not we should use steroids or should not. And then also, if we're going to use them, what dosing and duration should we use? So the decision on how to treat these patients largely comes down to individual patient characteristics, such as need for mineralocorticoid versus glucocorticoid effects, and what we believe is the main cause of the inflammation and the need for steroids. On the other hand, if the patient does have something like a concomitant influenza, you have to weigh the risks of harm that we've seen in studies for patients with influenza ARDS. And then something else that is currently being studied and is really up and coming with ARDS is the concept of ARDS phenotyping, which has included a phenotype of hyperinflammatory ARDS, which has higher mortality and different responses to certain treatments as compared to other phenotypes. So phenotyping could help us better understand which patients would benefit from steroids, as well as what the best regimen would be for that specific phenotype. So as you can see, there is evidence supporting use of more than one steroid in duration for ARDS. And as pharmacists, we do play a vital role in not only recommending and discussing the use of the steroid, but also dosing and duration, and then monitoring for adverse effects and appropriate use. Many patients, even those that don't have diabetes, will develop hyperglycemia from steroids used for ARDS, especially if we're using some of those stronger steroids like we use for the DEXA-ARDS study, which requires high doses of dexamethasone for 10 days. So this presents a great opportunity for pharmacists to intervene and make sure that blood glucoses remain 140 to 180 as much as possible. Some patients may need started on long-acting insulin therapy to keep their blood glucose levels in range after the steroids or during the steroids, and then they might need to stop that after the steroids are complete, or they might need the doses reduced. So it's just really important to pay attention to that because you might have to put patients on long-acting insulin that didn't even have a history of diabetes before they were started on the steroids for ARDS. So it's important that pharmacists play a role in not only starting the therapy, but also reducing or even stopping them to prevent hypoglycemia because we know that is just as harmful. Another important role for the pharmacist to ensure appropriate steroid use is in regards to the timing of steroid use. So I mentioned that one study that was by Steinberg in 2006 that found that steroids being used greater than 14 days after ARDS onset has an increased risk of mortality compared to placebo. So the role of steroids is really predicted to be mostly during that exudative phase of ARDS, which is the first 7 days of onset. So pharmacists can be helpful in ensuring that steroids are started as early as possible. And then finally, the pharmacists are playing a vital role in making sure that whatever steroid we choose is utilized at the right dose as well as the right duration. So thinking about the fact that if we're going to use dexamethasone, all the studies we have used the same dosing. So making sure we use the dosing that's associated with that. And then also when you're using some of those, if you're going to use methylprednisolone and some of those others, just making sure that we use the right dose and duration for those specific steroids. So to summarize, there is unfortunately not just one right answer when it comes to steroids and ARDS. So I know you are probably listening to this thinking that there's going to be this final conclusion of the steroid that I'm going to recommend, but unfortunately there's really no way to choose it because it is very patient specific. So you have to evaluate the patient for comorbidities or characteristics that may lead you to pick one steroid over another or not even use steroids at all in the case of some of those influenza patients. And then be sure that you're using the right dose and duration based on the literature we have available. And finally, one of the most important things about using steroids and ARDS is the timing for starting steroids because we've seen increased mortality when using it after 14 days of onset. So making sure those steroids are started early in the course to have the most beneficial effect, while we also are going to be monitoring blood glucoses and stopping insulin therapy. So that's all I have for you when it comes to steroids and ARDS.
What an incredible overview. Yeah, hopefully the listeners should know by now that very few topics I'm going to bring on are going to be black and white. And so I really loved you talking about not only the trials behind the different agents, but just also highlighting that we have these large governing bodies, right, with these authors from these big studies that you mentioned that kind of say that we don't necessarily know what to do with competing disease states and things like that. So, huge job security for us as pharmacists because we're balancing drug shortages, competing disease states, and those sorts of things. So I thought you did an awesome job highlighting not only the evidence behind, but all the things that pharmacists can do and help in these, most critically ill patients. So, Dixie, this was fantastic. Appreciate all your time, effort, and expertise coming on the podcast. Appreciate you.
Thank you.